Welcome back to the podcast. In today's episode, we're going to be talking about one of the most polarizing topics in modern metabolic medicine, the GLP agonist. Depending on where you get your information, these medications are either being called miracle drugs or dangerous shortcuts. Some people see them as life-changing and others see them as cheating. As a physician who treats obesity, insulin resistance, and metabolic diseases every day, I want to move this conversation out of social media sound bites and into science, physiology, and nuance. The GLP agonists are neither magic nor moral failures. They are tools. And like any tool, the value depends on how, why they're used, and are they being monitored. So before we go into details, what are these medications? We have learned about pathophysiology in previous episodes, and we have learned about glucagon-like peptide neurohormone in the gut. It is released after we eat, and it plays several key roles, like it's slowing down of gastric emptying, increasing satiety signals to the brain, improving insulin secretion and lowering glucagon levels, reducing appetite and food noise. So these medications they mimic this hormone, and they are part of body's built-in metabolic regulation system. People who struggle with dysregulation of this hormone, like insulin resistance, polycystic ovaries, or history of repetitive dieting, these medications come back in, help with regulation again. They restore the signals that should have already been there. We have learned about what causes weight issues and what goes wrong when the regulation system is not working. There is still shame and guilt around using these medications. Many people don't want to tell anyone that they are on these medications, and many people also feel guilt about it. Do we feel shame and guilt when we are treating blood pressure, thyroid, depression, diabetes? These medications should also not have any shame or guilt associated with them. They don't bypass discipline. They don't make it easy for you to lose weight. They just help with correcting the underlying biology. So who are these patients who can benefit from it? So the right patient, right indication. Individuals with obesity or overweight, BMI greater than 27, plus metabolic disease, patients with insulin resistance or pre-diabetes, patients with high body fat percentage like South Asian people, even with normal BMI, women with polycystic ovarian syndrome or postmenopausal women with metabolic slowdown, even perimenopausal women experiencing insulin resistance issues and worsening of their metabolic health, people with relentless food noise despite healthy lifestyle. These medications are not cosmetic weight loss drugs. They are metabolic therapies and should be used responsibly with adequate medical screening, lab evaluation, planning for the healthy nutrition, long-term follow-up, exercising, and also strategies to preserve muscle mass. When any of these steps are skipped, outcomes suffer. And that's where most of the negative backlash comes from. I also want to talk about the side effects, the complications associated with these medications, and some common myths. The most common side effects I see in my practice are the gastrointestinal effects like nausea, vomiting, diarrhea, constipation. These typically diminish over time, although you do experience them again anytime if you eat something that you're not supposed to eat, or when we escalate the dose. These agents also carry increased risk of gallbladder disease. That is one of the serious complications that we'll talk about. Gallstones and then inflammation of gallbladder can require hospitalization and surgery. The other common side effects we see is reflux and heartburn and indigestion, the gassiness. They are also managed by using heartburn medications, eating slow, frequent meals, and eating at least 3 hours before bedtime. Some of the less common but serious GI complications are slowing of gastric emptying and gastroparesis and bowel obstruction. They are dose-dependent side effects and can also be mitigated by gradual dose escalation and also avoiding the risk factors for these. The most commonly talked about complication with these medications is diabetic retinopathy and it was associated with Wegovy in the SUSTAIN-6 trial. It was later thought that it was likely related to rapid improvement in blood glucose, and it was not a direct drug toxicity. However, screening for retinopathy before starting Wegovy is recommended for patients with diabetes. Now, risk of low blood sugars or hypoglycemia. The risk is minimal due to their glucose-dependent mechanism, but it does increase if we are combining it with insulin or other diabetes medications like sulfonylureas. Now, the serious complications, pancreatitis, and there's also talks about pancreatic cancer, although it has not been confirmed in large clinical trials, but the caution is warranted in patients with high risk, recurrent history of pancreatitis, or even patients who have family history of pancreatic cancer. Now, there is another one that is talked about in social media, that is sudden loss of vision or blindness. The medical term for that is non-arteritic anterior ischemic optic neuropathy. In simple terms, what can we do about it? Nothing. There are no early warning symptoms, there's no signs, there's also no real way to screen for it, other than just maybe doing a baseline comprehensive and regular eye exam. It is actually a vasculopathic problem, so it is a stroke for lack of better definition. Can we prevent it? Unfortunately, no. Medullary thyroid cancer. It is a contraindication for anybody with personal history or family history of thyroid cancer, medullary thyroid cancer, the specific kind, and also multiple endocrine neoplasia, the MEN2 syndrome. Some other things that I've seen in this injection site reactions, a rash where you give injection, headaches, fatigue, hair loss. And some studies confirm increased risk of suicidality, although we are still studying that. The patients who should completely avoid GLPs are, like I said, the medullary thyroid cancer history or MEN2 syndrome, or the patients who have significant gastrointestinal disorders, like who already have or struggle with slow gastric emptying, or if they are on medications that slow gastric emptying, they should completely avoid being on GLP agonists. The other contraindications are pregnancy, breastfeeding. We don't have enough data on safety of these medications in those two situations. And then there is also some toxicity because the medications transfer to the baby. We also have to be cautious in patients who have pre-existing diabetic retinopathy with A1Cs greater than 10 who are traditionally uncontrolled diabetics. They require extra vigilance, extra monitoring when we initiate GLP agonists, particularly Wegovy. The next group of patients that we need to be cautious is elderly and frail individuals. The GLP agonists are combined with insulin or glucose-lowering medications like sulfonylureas, you have to monitor for low blood sugars and also for any diarrhea, because you don't want them to get dehydrated and start having issues with the electrolytes, with the volume, with kidney issues. This brings me to the final segment of this episode, is like, do I have to be on this medication for life? In most scenarios, yes. In some, not necessarily. Depending on the cause of weight gain and if you are able to sustain the long-term lifestyle changes, you might be able to go off of these medications if they have done the metabolic reset and you are transitioning to a structured support, then you are able to go off of these medications. It is critical to understand that if the problem is underlying biology, as it is in most of the scenarios, we still need to continue these medications even in low dose long term. It requires a discussion with your doctor and a nuanced discussion about what the long-term weight management looks like. What you do to lose weight is also what you need to do to maintain weight. So we continue to emphasize on nutrition, strength training, physical activity, regulation of sleep, management of stress, and hormonal optimization. These medications do offer a window of opportunity, a period where the brain is quieter, the hunger is regulated, and a behavior change finally is achievable and sustainable. In closing, I want to reframe the narrative around these medications and offer these medications as part of the solution, as part of the help that we need. If you have any questions, please feel free to go to my website and leave a comment. I'll be able to answer them in future episodes. Thank you for listening. In the next episode, we'll be talking about these medications specifically, Wegovy, Zepbound, and Mounjaro. Thank you. If this episode helped reframe how you think about weight, metabolism, or GLP medications, please share it with someone who needs a more compassionate, science-based perspective. And as always, talk to a clinician who treats obesity as a biology, not behavior. Thank you for listening.